Okay, so can everyone see the slides? Great, let me just move this window 1 second. Okay, so thanks for including me in the conference. Obviously, this is a really exciting conference, and I love conferences that try to go kind of across, classical economic fields and draw some commonalities. So this paper is joint work with John Kolstad, Thomas Minton, and Johannes Spinnowin. Johannes is here, and he can answer questions in the comments. So, there's been a lot of focus over the past few decades and in general on offering choice in regulated markets. And this paper is one example of studying a context where people are making decisions for insurance, and insurance is being provided in a private market that's kind of backstopped by a lot of public regulation. And so the success of these kinds of privatized programs, both in healthcare, retirement savings, et cetera, it really depends on whether consumers are making good choices in these markets. And, for this audience, I know I don't need to belabor this point that that's generally, there's much evidence that that's not always the case. And the key focus of this paper is going to be thinking about, the choice quality of consumers in an insurance context, but linking that to social determinants of choice quality, and probably most importantly, thinking about the implications for inequality. And so what we're going to be doing is we're going to be thinking about, first, are consumers making a good or bad choice in the realm of health insurance? And second, we're going to be using really very granular, detailed data on consumer characteristics to say, well, what are some of the correlates and determinants of these good or bad choices? And does this have implications for inequality and thinking about kind of whether goods are privatized, public goods are privatized? So our context is health insurance in the Netherlands. So Netherlands has a managed competition insurance market with heavy public regulation. You should think about this as kind of privatized provision of health insurance, but with a lot of public regulation. The key choice we're going to focus on is there's a standardized choice across insurers where they're allowed to offer deductibles ranging from 375 euros to 875 euros. So we're going to focus here today on this financially differentiated aspect of the choice. And the nice thing is that this dimension is essentially orthogonal to other dimensions of insured differentiation. So it's a simple choice, but it's a pretty important choice. And the nice thing is it's a kind of standardized choice for the entire country. And so we have a sample of all citizens in the Netherlands. You can see the table on the left here, and there's roughly 12 million people in the sample overall. Okay. Crucially, the data for this project really are kind of what makes it shine. So we have detailed health claims data for everybody. We have obviously insurance choice data, but I think most importantly and most novelly, we have all of these individual level variables on people's education, both level and type of education, their profession, what firm they work for, their income level, their debt levels, their wealth levels, who are their peers at work, who are their peers in their neighborhoods, and who are their family members. And so broadly speaking, what we're going to be doing is we're going to be using the blue pieces of data to say whether people are making good or bad choices, and I'll talk about that in a minute. And then we're going to be using the orange pieces to say, well, what are the correlates and determinants of this? And correlates, we're going to be looking at education, job, income, debt, wealth. We're going to try to do a causal analysis with work peers and location peers, and I'll talk about that. So the three key questions are: first, what are the key socio-demographic correlates of good deductible choices? Second, what is the causal impact of peer choices on good deductible choices? And third, what are the consumer welfare and equity implications? And in this latter section, we're both going to be looking at kind of what are the correlates of best and worst decision makers in this privatized benefit provision. But we're also going to be analyzing different policies and thinking about the impacts of those policies on inequality and efficiency. So I'm going to talk, since this is a short talk, I'm going to be brief, but I'm going to talk about the choice model and how we characterize what we call a good or bad choice. Since this is a very kind of behavioral motivated audience with a lot of, sophistication, what I'm going to say is we're going to be referring to this as kind of good or bad choice. One way to think about this in kind of very precise language is as a good or bad allocation. And so ultimately, consumers may choose not to engage with the choice process in kind of an inattention kind of framework. We're going to be calling that a bad choice, but really what I'm going to mean is kind of that they're not in the product, which is the best product for them in this product set. So we're going to simplify the choice environment, and you'll just have to trust me that this is a kind of very reasonable simplification to two choices: a binary choice of a default deductible of 375 euros or a voluntary deductible of 875, which you can elect. If you elect the voluntary deductible, you get a premium reduction, which is roughly 250 euros for a given insurer. And so, you know, taking those things into account and integrating into an expected utility model, which we have in the paper, you're going to take the extra deductible, or sorry, you should take the extra 500 euro deductible if the probability your total spending is less than 375 euros is greater than 50%, okay? And we have kind of a number of iterations in this and descriptions of this, but basically you should think about this as a pretty simple choice, and a pretty simple choice to assess. One nice thing is, of course, one key motive for insurance is risk protection, and the kind of optimality or the threshold for optimality and whether one choice is good or another choice is good, it's really not very dependent on risk aversion parameters, which range across the distributions estimated in the literature. So we're not going to estimate risk aversion, and we're just going to do, you know, in the paper, we do some bounds as a function of this. So we kind of a key underlying bedrock for what we do here is we use machine learning and the detailed data to predict a probability that individuals have costs in the low range versus in the high range. We have a lot of individual specific predictors, which you can see here. We do the prediction on 1 million people, and we have a holdout sample of approximately 12 million that we do the rest of the analysis on. Here you can see on the x-axis the prediction of the probability that you have low costs, so that your predicted spending will, or that your ultimate spending will be below 375 euros. The y-axis is the density. And here what you can see is if you're to the right side of this graph, you should be choosing the 500 euro deductible. If you're to the left incrementally, if you're to the left side, you should be taking the default deductible. And you can see that the kind of high and low risk aversion thresholds really don't have much of an impact on this choice. Okay. So, oh, and the last thing I should say is the risk prediction model fits really well. I'm not showing you that here, but the fit of that model is very good. So here, I'm going to show you quite a few charts now, which kind of have a similar format. So I am going to take a minute to kind of make sure, you know, I tell you about this format. The format for the charts is going to be on the x-axis. We're going to have the probability that you're low cost. So to the right are the people who should be choosing the high deductible. To the left are the people who should be choosing the low deductible. And then the y-axis here is going to be the share who are taking up the incremental deductible. Okay. And so here, what you can see based on the data is that people further to the right who should be taking up the higher deductible are more likely to do so. But what you can see is that here, if you look at the dashed line, the dashed line here is basically what people should be doing in kind of a strict allocation sense. Whereas you can see the blue dots are what people are actually doing. So this shouldn't be surprising to people here. The 375 euro deductible is typically a default option in this setting. And what you see is that people are sticking with the default option. They deviate from the default option based on their health status in a way that's pretty good in the sense that you have healthier people who are the ones who are deviating, but still way too few of those people are deviating, okay? So what are we going to do with this model? We're going to investigate the relationship between social factors and deductible choice. I'm going to go in two sections here. First, I'm going to talk about correlates of choice with human capital, financial capital, and environmental effects. And for these kind of three things, what we're going to do is I'm going to present for you both unconditional correlations as well as regression estimates. And so I'll talk about those things in turn, okay? First, some unconditional correlations. Here, this is unconditional correlations with education. And what you can see here are plots similar to what I showed you before, but stratified by level of education. So here we have less than high school all the way up to further studies, which means advanced degrees. And what you can see here is that people who have more advanced education, so further studies, college, high school, further studies in college, are making better choices, where better choices here means that you're sloping up more strongly, moving from left to right. So the people who should be choosing high deductible plans are more likely to do so. And this is, to be clear, this is an unconditional correlation. So there could be other things going on in the background, and I'm going to talk about that in a minute. This is the same chart showing by income. And so here, if you're in the fourth income quartile, which are the people who are earning the most money, you see those people making the quote unquote best choices. And they're the orange circles. And you see the poorest people here making the worst choices. So being less likely to elect the higher deductible when they should, okay? So what we do to make these kind of less unconditional or conditional on a range of things is we do a regression. And the regression has a dependent variable, the take up of the incremental deductible. And there are X variables, which are these covariates like education and income. And then H is the probability that your costs are low, okay? So we're gonna, for a given group, say people with a PhD or people with high education, we're gonna have both a level effect. So are you more likely to choose a high deductible kind of as a flat line moving up in these charts? But also, are you more likely to make the right choice? So are you more likely to make the best choice when you're in poor health versus when you're in good health? Okay, and this interaction term, the beta 3, is really the most important term here, because that's really showing, you know, are these people are people in certain groups really making better choices? And so this regression table shows these interaction coefficients for a range of factors. And the key thing I want to get across here is that in this one regression, what we're doing is we're kind of studying at the same time, simultaneously, education, income level, age, gender, and we have insurer fixed effects, which are kind of taking out any specific effects of a given private insurer. And so what we're finding here with these coefficients, and the way to interpret these, is that, for example, if you are in college or you have further studies and you're in good health, then you're 20% more likely than someone in the leave-out group, so below high school education, to make the right choice, which is to choose the high deductible, okay? And you can see here that the education variables are much more important in explanatory power than the income variables. So the unconditional charts, the education one is closer to what we're finding in the regressions than the income charts. In some sense, education is more predictive than income here. Then what we do is we look at field of study in education. And here we have many fields, and I just selected 6 here. And the regression results on the left show the lift in quality of choices for people in good health in specific fields. And what we find broadly is that people in more quantitative fields are making better choices. So for example, statistics, people who have a statistics degree are 20% more likely to make a good choice of choosing the high deductible when they're in good health, okay? Whereas people who are hairdressers or security guards are kind of making worse choices than the leave-out group, which you can see at the bottom, okay? I'll gloss over this, but this is kind of a table just showing you that we have many, many different fields, education fields. So I took out these 6, but we have quite a few fields, and we've kind of done the analysis for many of these fields in the paper. So then we have professional sector. This is the kind of job you have. And here we have some similar features where if you're working in business services or in insurance, you're more likely to be making a better choice when you're in good health. So you have a stronger gradient between your health level and your deductible choice, which is kind of what we're trying to predict. Okay, moving on to personal finance. Here we have similar regressions, and what I've taken out here, or I've kind of carved out for you in the regression table, are the specific income and financial variables of interest. In the background here, there are lots of all the other controls, so health, education, income, etc. And what you can see here is that people with higher net worth, so the people with the highest net worth, are 6% more likely to be making the kind of right choice when they're in good health, as opposed to people in the lowest quartile of net worth. And here in the bottom kind of section here, we're looking at things like liquidity. And so people who have savings of greater than 2,000 euros in their bank account, they're more likely to make a better choice, all else equal, by 3 percentage points when they're in good health. But it's not that strong an effect relative to the education and the income variables, okay? And here I've highlighted the fact that I'm so happy when I get to show these tables, because there's almost 60 million observations, because we're doing this for a 5-year period in the data, okay? Okay, so now I'm gonna move on and talk about kind of the next thing, which is the peer effects and the switchers design. I'll be very brief because I know I probably only have about 5 minutes here. And so
you have 4.
Oh, no. Okay, so what this peer effect switchers design is, you know, what these other regressions do is they take a lot of kind of long-term human capital type factors or financial factors and say, what's correlated with good or bad choices? What this is doing is it's taking our data on peers, so people who you work with or people in your neighborhood, and it's running an AKM style switchers model. And so if you move across firm or you move neighborhood, that's kind of helping us identify the causal effect of those peers or that firm on your choice, whether this is kind of a good or bad choice for you, okay? And here there's a couple effects that are being captured. One effect is the effect of your peers, and one effect, for example, in the firm case, is it could be that the firm has some specific education program for health insurance choice that's helping employees, something like that. This is a 2-stage process. You have fixed effects from a linear OLS of the firm on deductible choice, and then we regress those fixed effects on the average take up within the firm. So the first regression is using the switchers to identify the causal firm effect, and then the second saying is, well, what's the impact of that effect on take up, okay? And so here what we find is that if other people in your firm are more likely to be taking up the high deductible, typically this means making a better choice, then you're more likely to be as well if you switch into that firm. We find similar peer effects with neighbors. We look at these peer effects as a function of your health status, and we find that if you join a firm where more people are choosing the high deductible, or you're in a neighborhood where more people are, and you move, you move into one of these firms or neighborhoods, if you're in good health, you're more likely to make a good choice by electing the high deductible. But if you're in bad health, you don't increase your take up. So it's not that, it's basically switching people from defaulting into choosing a better choice for them. It's not inducing people to make the wrong choice if they're in poor health. Okay, so consumer welfare, and you know, I'll probably focus most on this in the last couple minutes. What we do is we set up a model of consumer welfare, and here the basic idea is just, you know, are you making a good or bad choice, and what's the value in this good or bad choice? So kind of placing a financial value coming from the expected utility model that I referenced earlier. Here, there's 2 cases that matter. You know, one case I call all else equal, which means, are you making a good or bad choice conditional on health status, which is kind of how we've set up this framework. The second case is going to be, you know, if you're in a specific group, is the health of this group correlated? Is health correlated with SES status? And if so, what does that imply for this group? So here, what this chart shows is it's a table that brings together all of this analysis and classifies people into top 5% decision makers and bottom 5%. The way we do this is we say, conditional on health status.
Just to heads up, we're down to 1 minute.
Cool. Conditional on health status, are you making good or bad choices kind of based on the model we've set up? And as a function of that, if you're in the top 5% versus the bottom 5% in terms of kind of the welfare implications of your choices, what are the correlates of being in the kind of best decision-making group versus the worst decision-making group? And so here you can see that education is highly correlated with being in the best decision makers. Your quantitative fields are highly correlated with that. You can see that your income is highly correlated so if you're poorer, you're in the worst, you're much more likely to be in the worst decision-making groups, etc. So kind of, this is a nice way to, I think, to summarize and bring these results together and show some of the key implications of these choice policy issues. Okay, I'm not going to talk about the counterfactuals in the interest of time, but what we do there is we take this framework and we study insurance mandates, and then we study smart defaults or targeted default policies. And we say, well, what are the implications of these policies for efficiency? But then what are the implications of these policy for if kind of social welfare when we also have aversion to inequality, okay? And I think that, you know, thinking about that in this context is really important given some of these underlying correlations. Okay, we also have a choice model that works on kind of predicting some mechanisms underlying these patterns. Obviously, I'm not gonna get to go over that right now. So let me wrap up. You know, I think what this paper does is it studies the entire population of the Netherlands. It studies an important choice that's been privatized but is heavily publicly regulated. Average choice quality in terms of the allocation is low. There's significant heterogeneity by key social factors: education, exposure to peers, insurers. The way, you know, the results turn out really show that choices are kind of systematically worse for lower income, lower SES consumers. And so an obvious implication of this is that choice-based policy can kind of exacerbate inequality. Smart defaults help a lot in this setting, especially for those consumers. And I think, you know, I didn't talk about the literature at all, and that was probably a good decision. But the one thing I'll point out is I think, you know, probably the closest paper, you know, that I've found to this is the Chetty et al. 2014 paper, which is on retirement savings in Denmark, and thinking about some of the correlates of whether people kind of opt out of the default option in their retirement savings programs, okay? I think a key difference in this paper is we're really able to assess whether the choices people are making, I think, are good or bad choices, whereas in that paper, I think it was more looking at kind of a specific positive outcome of whether people are opting in or out of a kind of the retirement default option, okay? Thank you, and looking forward to answering your questions later.
There we go. How's that?
Fantastic, thank you.
All right, excellent. So thank you for inviting me. This is joint with Mauricio Caceres-Bravo, Peter Hull, Amanda Stark. I realize this is the 16th presentation in 2 days. So what I would urge you to do is your memories of this talk will be colored by that fatigue. You need to update by about 1.5 to 2 standard deviations, whatever your experience of the talk is. It was actually much better than that. All right, so to preview our findings, what I'm going to try to convince you of in the next 19.5 minutes is that there are huge differences in causal mortality effects of health insurance plans. Despite this, consumers in their choices are only weakly responsive to these differences. This is a big problem for private health insurance markets. The principal potential benefit of competition among private insurers is that private insurers would have an incentive to innovate, and specifically to innovate on quality. So what we would like them to do is to do things like spend billions of dollars to figure out what physicians and hospitals will provide high quality care at low cost, or to invest in decision support. So you have an AIA to help physicians make better decisions. But they're not going to have an incentive to do that if consumers don't respond to improvements of quality in their decision making. Instead, insurers will have an incentive to invest in things that look like quality, but are not really quality. So in order to do all of this, we're going to need to address 3 empirical challenges. The first of these challenges is that consumers sort non-randomly into plans. So we need some way to disentangle if a plan has a low mortality rate. Is that because it makes people healthy, or is that because healthier people chose that plan to begin with? The second challenge is that RCTs and quasi-experiments, while we'll utilize them in our work, are not going to be powered to recover causal mortality effects for each individual plan. The third challenge is that given that we don't have estimates of causal mortality effects for each individual plan, it seems like it would be hard to estimate how demand responds to these causal mortality effects. So we're going to resolve these issues. We're going to resolve them by developing an empirical framework that allows us to combine observational estimates with many quasi-experiments. So we will specifically formalize how IV can be used to relate causal effects to observational measures. And we'll show that previous work that tried to do this, so for example, things like Chetty, Friedman, and Rokoff, where they're trying to validate teacher value added using teachers who move across schools, require a previously unnoticed condition. And that condition is, well, even if you randomly assign teachers to move across schools, teachers then might be endogenously assigned to classrooms. In our example, we're going to, even if whether a plan disappears is randomly assigned, people subsequently make an endogenous choice of plans. And we're going to need an additional condition on that choice in order to get identification. So we'll show you what that condition is, and then we'll show you how to test for that condition. We'll then extend this approach to show you how we can measure the correlates of causal plan mortality effects. And lastly, we'll show you how you can use our IV framework to estimate the willingness to pay for causal value-added estimates generally. So prior to this paper, if you had asked me a year ago, what would I say? Well, what most papers do in this literature is they get the observational value-added estimates, then they validate it using quasi-experimental variation, and then they just throw the observational estimate into a choice model and say we've estimated the willingness to pay for quality. That turns out to be wrong, because even if you validate the observational estimates using quasi-experiments, that doesn't mean that observational things like mortality rates are exactly equal to the underlying causal effects. There's still an additional source of noise and measurement error that creates problems if you just throw the observational measure into the discrete choice model. Okay, so this relates to a number of existing literatures. There is a large literature that estimates the extensive margin effects. What happens to mortality if people go from being uninsured to being insured? There's also a large literature that looks at choice among health insurance plans. So Ben and I have each written about 1,000 papers that look at choice among health insurance plans. What we always do, or most of the time what we do, is we say, hey, let's try to find a setting where we can hold physician networks and hospital networks constant so that we don't have to worry about the fact that some plans might be making people healthier than others, and we can just focus on financial choices. Now, there is some work that tries to say, okay, what if we need to value networks? Typically, that work will use revealed preference to try to value networks. What we'll show today is that outcome differences are first order, and revealed preference might be better than nothing, but it fails to value those outcome differences appropriately. All right, so our setting is going to be Medicare Advantage. Any person over the age of 65 in the United States who is enrolled in Medicare has the option of choosing either the public traditional Medicare plan or what's called a Medicare Advantage plan, which are private managed care plans subsidized by the government. About 1/3 of Medicare beneficiaries choose these plans. They're highly differentiated. They have different premiums, they have different benefits, they spend different amounts, and they have very different networks of physicians and hospitals. Right now, the only quality measure that's available to consumers for these plans are what are called star ratings from the Centers for Medicare and Medicaid Services. These star ratings very explicitly do not take into account mortality information, which in fact is not even publicly released. Okay, so we will study the entire universe of Medicare beneficiaries. We'll observe demographics, we'll observe enrollment, we'll observe mortality. We won't observe claims data. So what I'm going to do then, I'll show you how we construct what I'll call observational mortality, basically a transformation of mortality rates for every plan. I'll talk about our quasi-experimental variation. I'll briefly describe our econometric framework. I'll show you the main results, and I'll talk a little bit about mechanisms, the willingness to pay for mortality effects, and our simulations of alternative policies. Okay, so when I use the term observational mortality, what do I mean? Well, basically, I mean the plan fixed effects and a regression of mortality on plan effects, and then controlling for stuff like age, race, sex, and dual eligible status. That's whether they're also eligible for Medicaid, also controlling for county and year fixed effects. So we're looking at relative effects within a given choice set. Okay, I said basically fixed effects because we also apply this empirical Bayes shrinkage thing. I'm not going to describe it, but assume we do it correctly. So what happens? Well, here are the results of the empirical Bayes shrunken risk-adjusted observational mortality effects. If we do this without any controls included, the standard deviation of the plan level mortality effects is 1.1 percentage points. If we do it with controls, the standard deviation is 0.9 percentage points. The average one-year mortality rate in this sample is 4.7%. So if you thought that these estimates were causal, and that's what the rest of the paper will be about, but if you thought that they were causal, this would suggest that a plan that is one standard deviation better reduces mortality by about 20%. So that is potentially a very large effect. Of course, what we want to know is, are these effects causal? So to investigate this, we're going to use quasi-experimental variation arising from plan terminations. Many of these terminations arise due to a legislative change over the period that we're studying that changed the reimbursement for a certain type of plans. We will specifically leverage the relationship between plan terminations and inertia. Absent terminations, beneficiaries enrolled in high and low mortality plans almost always stay in those plans. They almost always choose the same plan they were in the previous year. Following terminations, consumers tend to regress to the mean in their plan choices, choosing plans that look more typical, at least in terms of observational mortality. Let me show you that point graphically. On the x-axis here, I'm showing you the lagged observational mortality. In other words, the observational mortality measure, the shrunken risk-adjusted plan effect for the plan that the person was enrolled in the previous year. On the y-axis, I'm showing you the observational mortality measure for their current plans, which it's an attribute of the plan. What you can see from the blue line is, if your plan doesn't disappear, then the observational mortality of the plan you were enrolled in last year is a really, really good predictor of the observational mortality of the plan you were enrolled in this year. Most people are inertial. It's pretty much a 45-degree line. If your plan does terminate, what happens? Well, people who were enrolled in really, really good plans, low mortality plans, end up in slightly worse plans. People who were enrolled in really, really bad plans, high mortality plans, end up in slightly better plans. And actually, when I say really good and really bad, I should say provisionally really good and really bad. What we're going to try to figure out is, are the plans that look really good and really bad according to the observational mortality actually really good and really bad? So now let me show you another slide. It looks really, really similar, but I have made a fundamental change. On the x-axis, I still have lagged observational mortality. But now on the y-axis, I have the realized mortality of that beneficiary. So what does this graph mean? Well, if you're in a non-terminated plan, the mortality rate of the plan you were enrolled in last year is a pretty good predictor of whether you die this year. If you are in a plan that terminated, if you were in a really, really good plan that disappeared, you become much more likely to die. If you were in a really bad plan that disappeared, you become much less likely to die. So this is consistent with the story where the plans have a causal effect on your mortality. It's not consistent with the story where, oh, it just so happens that it was healthier people who chose this plan to begin with, and whether the plan disappears and they're forced to re-enroll or not, they still end up being healthy. Okay, the mortality rate changes when their plan terminates, inducing them to enroll in a different plan. So let me very quickly describe our econometric framework. Beta J are the average treatment effects of each plan J. We're going to consider an infeasible regression. If we observed those average treatment effects, the causal effect for each plan that we want to estimate, we don't, but if we did, we could regress them on the thing we do observe, the observational mortality rates, and we could recover this object lambda that we call the forecast coefficient. So lambda mu j is the best prediction of causal mortality effects, the best linear prediction of causal mortality effects, given the observational mortality measure. All right, we are going to show you how to use a particular IV regression that corresponds to the graphs I was just showing you in order to identify this forecast coefficient, lambda. I'm not really going to have time to describe in detail, but I want to point out one feature of the math just to give you a little bit of intuition. So we have this infeasible forecast coefficient. we have an equation for realized mortality, YIT, that is observed. We can substitute in this infeasible regression into the equation for realized mortality. The thing I want to note, so somehow we're going to instrument for observational mortality in order to estimate lambda. The thing I want to note is that that instrument satisfies two exclusion restrictions. It has to satisfy the usual exclusion restriction that the instrument only impacts realized mortality via which plan you're enrolled in, via the observational mortality of the plan in which you were enrolled. So it doesn't impact realized mortality through some other channel. That's the epsilon thing. It also has to be that the instrument is uncorrelated with the forecast error in this infeasible regression of causal mortality effects on observational mortality effects. That's a really unintuitive object. So I'll return to what that means in a second, but it's an additional condition that's needed quite generally when you use IV to validate value-added models. Okay, so first, let me talk about the conventional exclusion restriction. The kind of thing that you would be worried about in the graph that I showed you earlier. Suppose that the people enrolled in really good plans, the people enrolled in good terminated plans happen to be older. And that is why their mortality went up. The people who were enrolled in bad terminated plans happen to be younger. And that is why their mortality went down relative to the people in bad non-terminated plans. That would be a problem. It turns out that we have very good balance. So terminated and non-terminated plans do not differ at any level of lagged observational mortality in terms of predicted mortality. That's things like age, sex, dual eligible status, etc. All right, so then I said we need this second condition. The idea of this second condition is even if terminations are as good as randomly assigned, people make an endogenous choice following the termination of their existing plan. And so we need some condition on those choices for us to have a valid IV in order to get consistent estimates of the forecast coefficient that relates the observational mortality measure with the causal mortality effects. What is that condition? Well, we need the plans that people choose following termination to be typical given the observational mortality of those plans. That's still really unintuitive. It's really hard to wrap your head around. In the paper, what we do is we give a micro foundation for this. We give a general class of discrete choice models such that if choices are made according to those discrete choice models, then this new condition will hold. And we show that this subsumes most of the models that people estimate in empirical IO. In the paper, we also develop balance tests for this condition. So let me just note here, this fallback condition is not unique to our setting where we have terminations and then an endogenous choice or something like that. The fallback condition is needed whenever you do IV validation of value-added models where the IV is non-trivial. What I mean by non-trivial is if you actually have explicit random assignment of students to schools, or you have explicit random assignment of beneficiaries to health plans, then you have a trivial IV and you're fine. But if you have a non-trivial IV where you say, well, teachers move across schools, but it's not that the students themselves are randomly assigned to teachers, or you have that a termination induces people to move across plans, but we haven't perfectly randomly assigned them to every plan, then you will always need something like this fallback condition. So we get into it in much more detail in the paper. It's pretty hard to describe in 20 minutes, so I'll leave it there. Oh, I'll also show you, we did these balance tests, and look how nice it looks. It looks great. So you should probably just believe me that the fallback condition is at least not rejected in this setting. So we have these conditions. Given these conditions, we estimate the forecast coefficient that relates observational mortality to causal mortality effects. We get a forecast coefficient of 1. Now again, that forecast coefficient of 1 does not mean that observational mortality estimates are equal to true causal mortality effects. What it means is that observational mortality reliably predicts true mortality effects. There can still be selection bias and all kinds of underlying errors, but if you increase observational mortality by 1 percentage point, the best prediction of the change in causal mortality is also 1 percentage point. This in turn implies that the variation in causal mortality effects is at least as large as that in observational mortality effects. So a 1 standard deviation improvement in plan quality implies at least a 19% reduction in 1-year mortality. Is this crazy?
3-minute warning, Jason.
Okay, thank you. Is this crazy? Well, we know that there are large extensive margin effects of getting health insurance. We know there's large mortality effects of moving from places where people are healthier to places where people are sicker. We know there's very large effects of going to different hospitals. We think this magnitude is not implausible given all of these. In the paper, we think a little bit about mechanisms. We show that higher premium plans, plans with more generous donut hole coverage, plans that spend more, tend to have better outcomes. Importantly, plans with higher star ratings do not. Star ratings, the one quality measure people have, are uncorrelated with causal mortality effects. Next, we recover the willingness to pay for these causal mortality effects. I'm just going to say in 20 seconds how we do that. You can read the paper if you want the details, but basically we estimate these discrete choice models. We recover mean utility. We use our fancy IV framework to run an infeasible regression of causal mortality effects on mean utility. We invert it. We recover preferences. We find people are willing to pay $200 for a 1 percentage point reduction in mortality. That's about 100 times smaller than we would expect given the value of a statistical life. So then we do all these policy simulations where we try to assign people to better plans. The upshot of these policy simulations is, I'll tell you just about one of them. If we get rid of the 5% of plans that are worst in terms of their mortality effects, and then we randomly assign people to other plans, then among the people who were thus reassigned, their mortality would fall by about 1%. That's a 1 percentage point. That's a 23% reduction in mortality. Given typical estimates of the value of a statistical life, this should be worth at least $10,000 in the first year after reassignment for each of those beneficiaries. So these are enormous effects. All right, so to conclude, there's significant variation in mortality effects of Medicare Advantage plans. Consumers are mostly insensitive to this variation. I'm sure in this audience, everyone is thinking, what's the mechanism? Why are consumers not responsive? Well, my view is I think that that is super overdetermined. I think that if you gave, one thing is people don't have information about mortality. If you gave people that information, I think they would be slightly more responsive, but they still would not respond to anything close to what the value of a statistical life says. I think the next problem is that people would be skeptical of that information. They would rightly wonder, have we actually figured out the mortality effects for them? Suppose you could assuage that skepticism. I think the third problem is that without doing a master's degree in economics, they wouldn't be able to conceptualize this question of, oh, am I being consistent across all these different settings and how I weight life relative to other things? Is it possible that by eating more unhealthy foods, choosing a better health plan, but buying pizza instead of sushi, I could have more money and more life and better tasting foods? That's a hard thing to conceptualize unless you spent many, many years studying economics. It's not clear we should expect people's choices to be consistent in this respect. So let me just end by mentioning a couple policy responses. One is we could give people risk-adjusted mortality information. I think that would help. I think it won't get all the way towards consistency with the value of a statistical life. A second thing we could do, instead of subsidizing plans with high star ratings, we could subsidize plans that perform well in terms of risk-adjusted mortality. A third thing we could do, we could audit bad plans and possibly remove them from the choice set if they don't have a good explanation for why they had bad mortality effects. Lastly, I think our results strengthen the already strong case for integrating health insurance and life insurance. For saying if you provide health insurance, you also must provide a life insurance policy so that you, as the health insurance company, will have a big financial incentive to help people live longer. All right, thank you.
Thanks a lot. Sarah?
Great. Let's see here. Can everyone see that okay?
Yes, that's great.
Great. Great. Well, thanks so much. It was a pleasure to read both of these papers. They're very high quality, very interesting. I learned a lot from both. I'm going to start by just summarizing the session. In the first paper, we learned that consumers are making bad choices because they were choosing insurance plans that were too generous. And then in the second paper, we learned consumers are making bad choices because they are choosing insurance plans that aren't generous enough. So, you know, right away, you're in a behavioral economics conference. Nothing consumers do, it makes any sense, right? If I had a sort of overarching comment that would apply to both papers, it's that, if you talk to a non-economist about, why health insurance is important or why they buy healthcare, they might not mention consumption smoothing. They might not mention risk aversion. A lot of times it's something like, oh, so I can get healthcare, so I can get my drugs that I need to take. And while both papers are engaged with really interesting aspects, either the financial aspects in paper 1 or the quality aspects in paper 2, both are pretty light on how plan choice affects what I think is probably the main thing that a lot of people care about, which is how much care they get to use, the quality of care that they get to use. And I think if we want to draw policy implications from either of these papers, that's something that should be grappled with a little bit further. So in the first paper, so I'm going to give comments sort of turn by turn. So in the first paper, there's a sort of setting in the Netherlands where people are choosing between a high premium, low deductible plan and a low premium, high deductible plan. And most people are choosing the low deductible plan. And the authors argue this sort of reduces down to a lottery where you sort of win 250 euros if you have low health spending, if you're healthy, or you lose 250 euros if you have high spending because you've saved 250 on the premium, but then you have to pay the 500 euro deductible. And the argument is that if you have sort of risk aversion typical to the literature, you should be willing to sort of play this lottery if you have a chance of winning that's at least 50.06%. So I sort of thought to myself, like, would I play this if someone came up to me? And I thought, I probably wouldn't, which of course led to sort of a lot of introspection and a lot of thought about my decision-making process, but ultimately led me to conclude that no, it couldn't possibly be me. So where are these kind of risk aversion parameters coming from? That's a bit facetious, but it seems like they're coming from other settings where people are making choices about deductibles, where people are sort of assumed to be making choices out of a utility maximization framework and then kind of applied here. And so, that's why we're concluding that they're sort of under typical risk aversion parameters, the choices, it looks incorrect. It made me wonder that if this paper were written first, if I would be sort of discussing a paper right now about how people in the auto insurance market are like way too risk loving. I'm not really deep into this choice literature. I had to Google the difference between relative and absolute risk aversion before reading the paper, but it did strike me as like a little bit of a circular logic. Another comment on this is the authors provide some, great descriptive information up front on what is correlated with choice quality. And personally, for my taste, I felt like that was already like super interesting and a sufficient contribution. And then they move on to trying to make a stronger causal claim using people that either move to different neighborhoods or that switch to different firms. And I know this is a very popular design, but I think that there's sort of a lot of threats to identification in this model that this paper is actually sort of uniquely positioned to shed some light on, right? And when I say threats to identification, I mean, the reason that people move or switch jobs could be that they have a new baby, that they're changing careers, that they've just graduated and they're starting on a new career, or maybe they just got married. These all sort of generate these kind of switches, and these all affect demand for insurance. Now, that relationship itself is not enough to be concerning, but you might also think that these sort of endogenous moving choices are correlated with choice quality at the destination, right? So if I'm switching into a more analytical kind of position or a more analytical occupation from my previous occupation, and that's why I've switched jobs, then it would make sense that my peers might also be more analytical. And this is sort of an individual level threat to identification that's separate from the comment that there could just be like firm level heterogeneity. This is actually something about the individual that could change in a way that's correlated with destination peers. Now, I don't know if realistically this is like a meaningful concern here. I actually think it, since you have such incredibly rich data, this is sort of a really unique opportunity. You could look on the left-hand side and look for this specifically, and maybe that's not for this paper, but I think it could actually even contribute to the literature that uses switchers and movers more broadly, where a lot of the times it's set in the US where we can't really observe changes in marital status or changes in income that happen around the time of the move. Another suggestion would be to look at job changes where you stay within the same occupation. I'm working at a beauty parlor. I moved to a different beauty parlor where people are making a little bit different choices. Maybe we'd be less concerned about that sort of identification concern in that setting. And then I guess my last comment here is, in the authors, and this is not, they didn't just forget about this or something, this is an explicit choice, that they sort of explicitly choose to ignore the impact that the deductible has on utilization. And because they ignore the impact it has on utilization, they ignore the impact it has on health. But we know from Ben and his co-authors, other very excellent work, that when consumers get into higher deductible plans, they use very different types of care, and they don't use care very well or thoughtfully. They don't make very good decisions on the healthcare front. They cut back on healthcare that we think is actually pretty cheap and really high value and could prevent serious illnesses from arising. I think this is a concern in the setting because the people that are making sort of the bad decision about the plan, these are probably exactly the same people who would make the bad decision about, should I keep taking my, my medicine that prevents heart attacks because I'm under the deductible. They might be the exact same people who over respond to the spot price, right? So I think if the results from Jason's paper is right, you might actually have the classifications exactly backwards in your paper. It might be the people that are going into these more generous plans that look like they're making this big mistake. They might actually be making the right decision because they sort of know that they're going to behave kind of foolishly if they have more cost sharing exposure, right? So I think at the very least, my opinion would be, you might want to say how big of a health effect might have to be present in order to sort of justify these choices. And maybe that health effect would just be so incredibly large that it would be unbelievable. And so you can say, rest assured, we are actually classifying sort of good choices as good, or I should say good allocations as good. Okay, anyway, moving on to extremely large health effects based on the design of your insurance. The second paper looks at the impact of plan exit for Medicare Advantage market. And Jason explained it extremely well, so I won't spend too much time summarizing, but basically when sort of a bad plan leaves the market, people in that plan tend to move into a better plan. When a good plan leaves the market, people in that plan tend to move into a worse plan. And these sort of changes that they observe imply very, very large causal impacts of sort of plan design or plan choice on mortality. So moving someone to the best plan, or moving beneficiaries to the best plan, would reduce annual mortality by nearly 2 percentage points, which is a 40% reduction off of baseline mortality. So quite chunky effects here. So they're really, really big effects. Could consumers possibly be making such foolish decisions? I would say yes. It seems like consumers are leaving tons of statistical life on the table all the time. So I can say a lot of my work is on Medicaid. It's a free program. Almost no one pays premiums. There's almost no cost sharing to use care. And yet only a small fraction of adults who are eligible sign up for it. It's very perplexing. And there's been RCT evidence recently where the IRS sent letters to people encouraging them to sign up. And much of the coverage that people gained was again, completely free Medicaid coverage. All they had to do was fill out a form. And in this RCT, they estimated that, coverage reduced mortality by 0.2 percentage point per month, right? So we're talking about more than 2 percentage points in a year. So I think, to me, these effects are believable. I think the authors know that this is the sort of big, huge question mark that readers have when they read this paper. What the hell is going on in these plans? Like, what are these bad plans doing that is, killing their beneficiaries? What are these good plans doing that is helping their beneficiaries? I mean, the theory is consumers get into a bad plan, and then the middle step is that they use less care, maybe they use lower quality care, something happens in the middle, and then they die. Right, and there's not a lot at what's going on in the middle here. So they show that the good plans have higher premiums, they have more generous coverage. Seems like they're spending more, but it's hard to get any further than that. So I'm going to give a couple suggestions of other data you might want to look into. First, possibly the Medicare Current Beneficiary Survey. It's obviously a much smaller sample than the 100% extract that you're using, but if mortality effects are large, then access effects have to be like even much, much larger than that, right? Because some people get worse access, and then some fraction of those have a health event, and then some smaller fraction of those die. And even if you couldn't estimate causal effects with this data, you could at least potentially kind of characterize the good and bad plans based on like what beneficiaries are saying about how long it takes to get into a doctor, et cetera. Some hospital discharge databases have insurance plan name, including like which Medicare Advantage plan patients are in. And then I guess my other suggestion, if you can't sort of get directly at this sort of middle step, would be to look into possibly getting the cause of death information. That would provide some at least indirect evidence on what the mechanisms are. It would be interesting to know, is this all mental health related deaths? Is this all cardiovascular disease or diabetes? Or is it sort of spread out across different causes of death? It could also provide potentially like a placebo test if you look at people who die in car accidents. Maybe if they die on the scene, their health insurance might not affect their mortality rate. I don't really see people use cause of death information with the Medicare beneficiaries. I don't really know why that is. When I go on ResDac's website, it's just, it's just a file that you can request through the normal process, but maybe there's some like hidden kind of costs or barriers to getting this file that I don't know about. But it seems like it would be available and it might give some of that, that's some of that good flavor about, what's going on. So this paper was so intriguing to me, and I just hope that it spurs a lot more research going forward about, there's some pathway from coverage to receiving care that's broken down, and we don't really know what players are failing here. Like if it's patient cost sharing, then they're making sort of these irrational choices where maybe they have small cost sharing, but it's having this big value of statistical life cost to them. Maybe it's insurance companies networking. Maybe the insurance companies don't know what hospitals are low quality. Maybe it's on the physician side. Maybe the physicians are getting lower reimbursement from the plans and they're providing worse care as a result. Jason, please don't tweet that. I don't want any sort of memes with incompetent economists over my face from angry physicians. But that's all that I had. Thanks again. This was both really, really great papers, and I'm interested to hear the Q&A too.
Okay, thanks a lot. Let's see. Stefan, do you want to manage the Q&A?
I'm happy to.
I
But
guess we should give Ben and Handel a chance to respond first.
Exactly.
So Ben, do you want to take a few minutes to respond, and then Jason?
Sure. Yeah, I'd love to. First, let me say thank you to Sarah for the awesome discussion. It's a lot of effort to discuss two papers like this, and the papers are pretty, different in spirit. So I really appreciate your effort a lot. I thought your comments were awesome, and I'll be brief just because we want to have a kind of discussion on both papers. But I think I really liked your comments about the movers. Especially I'd kind of classify what we're doing there right now as what I would call kind of state of the art for kind of the labor literature and labor adjacent literature that does these kind of AKM style designs. And I think, I hadn't thought about your comment about basically even looking a little more at what are the correlates of the movers in kind of the multifaceted admin data. And I think that's just interesting in and of itself for this whole literature that uses these kind of mover designs. So I actually really appreciate that comment a lot. Your comment on kind of the moral hazard and the what does a deductible do, the prior paper I wrote, I think it's very, very well taken. One of the nice things for us, and I don't know how nice this is, but I think it helps resolve this at least a little bit, is that in our setting, because the more comprehensive insurance is the default option, basically what we're getting is we're getting kind of the active choosers, or the people we're calling the more sophisticated good choosers, moving into the high deductible plan. And so there is some degree of selection there. It doesn't necessarily mean, in the way you said it, that if these people are then foregoing lots of care, that would still be bad and would still mean that they had made some mistake. And it gets into this realm of, when they make this choice, are they kind of forecasting that they're going to make these medical errors in their own medical care, et cetera. Now, we have looked at this a little bit, and the people who choose the high deductible do have some lower utilization. I don't believe it's very lower. I think it's about 5% is my take. you know, that can matter. And so I would, you know, we're not totally ignoring that. The one nice thing, and this is the last comment I'll make before throwing it over to Jason. The one nice thing is that in the Netherlands, kind of the context we're studying, the differentiation across the insurers is much, I'd say much narrower than it is in the US, quite a lot, quite narrower. In the US, the network definition is actually kind of one of the key features of what differentiates plans, which kind of motivates Jason's paper. In the Netherlands, I think it's really, really much less so. And so, you know, on your earlier comments on that front, I think in some sense the nice thing is that the deductible choice here, you know, it's at least pretty clear that that choice is pretty orthogonal to these other dimensions. It doesn't mean that those dimensions you're talking about aren't super important and matter. So I think for that, we're kind of viewing it orthogonally, but for the moral hazard stuff, I think that's kind of a very, you know, a relevant comment.
Can I just add one thing on the worries about people foregoing on valuable healthcare? So not all health expenses are subject to the deductibles. So visits to general practitioner, maternal expenses, and things like that are always fully covered. So that should reduce that concern a little bit as well, I think.
Sorry, let me actually just add one more 30-second thing, which is Sarah did also give this very nice comment about the risk aversion, and there that's not something I'm concerned about. Just because essentially here what the point we're trying to make is that, ignore the moral hazard stuff for this comment, but like the point we're just trying to make is that if you're someone who's predicted to be in good health, there's basically no level of risk aversion that should justify you choosing the low deductible plan, the more generous plan. You would have to, even if you're using kind of CARA or whatever, or if you just have some kind of more heuristic based model or alternative model of how people make these decisions, there's almost no model that should kind of rationalize it, just thinking about the risk element, not the other elements. Thanks a ton.
Yeah, so I think I pretty much agreed with everything Sarah said. So just a few points. So on the cause of death stuff, we had tried to look into that like several years ago, but I suspect that actually you're completely right that, like, who knows, maybe it wasn't available several years ago, but as far as I can tell now, it looks like it is. So we should probably get that. And that seems super helpful for understanding the mechanism. And
I saw a comment from Ziad Obermeyer saying it stopped a while back.
Well, but I think it looks like, then Sarah responded, it was like, no.
Oh, I see, okay.
So, yeah. So I think, who knows, maybe
I'm behind the times, all right.
It might have changed over time, but my suspicion is that it actually is there, and we just, now we should use it. So, okay, and then the and on the last point about the mechanisms, I mean, basically, we looked at the mechanisms we could with the data we have available, but I 100% agree, like what we are working on in follow-up work, assuming that everyone here funds our grants, not looking at anyone specifically, but, you know, whoever the referees happen to be, that you should give us lots of money is what I'm saying. So then what we are looking at in that follow-up work is specifically the network angle. So whether it's the case that, so basically we're estimating the physician and hospital fixed effects, then combining that with network data, and then building up the inclusive value of the network from that. Now, even that though, I think one of the things you highlighted in your discussion is that when we do that, I expect that to be more important than maybe like premiums or something. Maybe that explains another 15% of the variation. I don't expect that that's going to give us like an R squared of 1, right? I suspect that at the end of the day, there's still going to be this huge residual. So I think there's a lot of room for work, because there are many things that plans could potentially be doing to impact health outcomes that wouldn't be in the network data. Like maybe it's just like, oh, the plans that have better administrators or that are doing a smarter job of doing the prior authorization. Like some plans really hurt health through that, and some plans do it really well. And we could list like 10 things like that. And so I think there is ample room for follow-up work to try to understand what those mechanisms are.
If I could just, Jason, like I'm a little shocked at the numbers you're giving in terms of the effects.
Yeah.
I think that you were surprised at how big they are.
Yeah.
And that raises an interesting question, which is if we are uncovering information that we ourselves didn't know. You know, nobody knew.
Oh yeah, that's what I think is happening.
Yeah, so nobody, but that means that there's that the chance that the decision maker was correctly internalizing that is kind of zero.
Yeah, that's my feeling. I think there was
Yeah,
no
no, I mean, you'd
yeah.
expect
It's gotta be 0%.
Yeah.
Yeah, so literally it's like one of those things where, and that now does seem to mean, and I, you know, that I understand that providing information sometimes doesn't work.
Yeah.
This is one of those kind of red alert, you know that you may die, you know, did you know that the plan choice, you know, and here's the one that will save you to, like, I don't think
I'm 100, yeah.
you might do a lot here.
I'm 100% on board with that. Let me, one point I would say is, I think if I had presented this, you know, in 1988 at a conventional economics seminar, I had presented our estimates and I didn't present the stuff about willingness to pay, I think everyone would have been like, well, you know, everyone can tell that some doctors are good and some are bad. And I know Mass General is a good hospital and this other hospital is a bad hospital. So people are incorporating quality when they make their choice. So I think people are trying to incorporate quality. I think it seems obvious to me that it would be really, really hard for them to do that in a way that gets close to the truth. And that, like, now it could have been that they were off by, you know, it was 20% of the truth as opposed to 1% of the truth or something like that. So I think it's
especially with this, you know, Sarah made the point. I mean, we only, now we're stunned to find the channel. Like, what on earth is going on?
Yeah.
Jason, I actually have a quick question, which is that, you know, as you know, in the literature where we've both wrote zillions of papers, there's all these, a lot of the papers are estimating brand effects. So kind of parameters that are kind of vague parameters, which are saying, well, all else equal, you prefer this plan over this plan. And I was curious, like, whether, you know, those from kind of, for example, from another study or from this study or whatever, whether those are correlated at all with these factors, with your estimate.
That's very interesting. We haven't done that yet, but that's a great suggestion, actually, to the revealed preference brand effects. How correlated are they with the beta OES? Like, I guess.
Yeah, it speaks directly to Andrew's question. And, like, for example, if those things are uncorrelated, that's super interesting.
Yeah, I think that they almost have to be uncorrelated, given, like, when we do this willingness to pay thing, that would include the brand effect variation, sort of. So it's like, that's almost exactly what we're doing, but there's like a subtle difference. But I think they're very closely related. So I think it basically suggests that. And, like, the further point that I would make about, like, the size of these effects, I sort of see this as, like, very conciliant with a big change that has happened in health economics in, like, the past 15 years. Like, I think circa the year 2000, if you talk to health economists about, like, healthcare and quality, they would be like, well, different parts of the United States all spend different amounts of money, but there's no quality differences. Like, quality is all about your diet and whether you exercise, and healthcare can't do anything. And then I think in, like, the past 15 years, there's been, like, one paper after another that shows that view is wrong. That it's like, getting health insurance matters a lot, which physicians you go to matter a lot, which hospitals you go to matter a lot. That in fact, like, when we use better causal methods, we do find big differences in quality from different types of health.
Okay, well, it's 4 p.m. Should we stop here?
Can I ask a closing question?
Yeah.
Go for it.
I came to this conference hoping I would leave knowing what attention is. But I feel like I'm just as confused as I used to be.
But that's because you just asked a meaningless question.
So
maybe it will teach you not to ask meaningless questions.
You must have not paid attention, Gautam.
Attention is whatever you define it to be in whatever context you define it.
Yeah, this is what seems to make it so hard, though, in our, like, going from reading, we read lots for our sleep paper. We read so much sleep medicine and cognitive psychologists studying attention in the context of sleep. And going from there to economic things and work and all of these outcomes was just extremely challenging. what's exactly what to measure, what kind of outcomes, what would you see there. It all felt like, we had very diffuse priors on it.
Yeah, and it's also like, I mean, it seems like even just attention in the way that you were talking about it, Gautam and Sapri, versus kind of what I'm talking about with kind of, choosing insurance plans or something like that. Even those things are just so different in the sense of one is kind of a very micro minute to minute kind of thing. And the other one is much more of like, am I going to deviate from some default once a year? And I think even that, those things may require very different models.
Right. So it's like attention probably isn't really one thing. It's like 30 different things.
Exactly.
And there's like a whole bunch of different underlying cognitive models for these different situations that have some commonalities, but it's like,
It's the cost function on anything, really.
Okay.
As revealed by the choices. Well, I want to thank you all so very much for showing, and I've been really enjoyable and a wonderful time. And I want to thank Anne Stubing and Ashwita Palakar for making it happen, which was not trivial, and holding me up and allowing me to look like I function. So that was wonderful. Thank you very much. Thanks for being here.
Andrew, thank you so much. And thank you, Anne.
Thank you.
Okay, deal.
Thanks a lot.
Goodbye.
Bye, everyone.
Bye, everybody.
Bye.
Thanks for coming.
Thank you.